Stanford University.
Thank you. I'm very glad to be here. As Nora introduced, I am a clinical associate professor at Stanford. My job is really to teach. So when she asked me to consider giving this lecture, I was very happy to do it. I am the director of the residency training program. So our 16 residents are under my charge, and our hope is to train them well to take care of the population and represent Stanford in the best way possible. Tonight, I'm going to be lecturing on rashes that itch. And this is always an interesting topic because we all get these. And there are many different forms of rashes that can cause an itch. And tonight, I'll go over 5 of the most common types. I wanted to begin by saying that I have never taken a cent from any drug company. During this lecture, I will refer to a couple of medications. Again, I've never taken anything from any of them. Maybe I should. I hear that they pay a lot. We've all heard that we should never scratch. So here we have a janitor cleaning out a dermatology office who happened to answer the phone. He says, he states over the phone to the patient, "That's right, scratch it like mad." And I think many of us have gone through situations where we feel this way, that it feels so good to scratch. And so why is it that dermatologists are so hesitant to have us do that? Well, we're going to go over some of the most common causes of itchy rashes, and hopefully at the end we'll talk about ways where we can treat these rashes without scratching. We've all been tempted to do this. We would like to, and there's certain parts of the back where you just can't reach. There's this little, I've been told to use a little arrow here. Let's see here if this works. There's an area right here that's very, very hard to reach, as you all know. And so we've been tempted to be, many situations to scratch this way. There are multiple ways of doing it. Scratching can be accomplished by a back scratcher, which you can buy for $3, and it works very, very well. Sometimes my patients have brought me their back scratchers. They've scratched so hard that they bring me the stub of the handle because they've scratched and snapped the little wooden thing. So the $3 ones, they don't work very well. Now on the right, on the left there, you'll see another instrument that many patients use to scratch, a towel. And so you would think the patients are so good at not scratching, and the only time they give in is after a bath. They're drying themselves off. They don't think it's scratching, but boy, do they dry really vigorously, and it feels wonderful. So there are multiple ways to scratch, and so we'll talk about the right way to towel off. And the first cause of itching that I would mention is dry skin. Now, as Nora mentioned, I'm going to be using a lot of photographs in this lecture. And my wife, I used to like to leave my dermatology books out on the coffee table. She would then subsequently take them and hide them because some of the photos that you'll see can be quite bothersome. So I apologize ahead of time. But these are truly the causes of itching. So the first one is dry skin. We call it xerosis. Xerosis is a condition in which your skin, in seasonal variation, can become very dry and very itchy. And for many of us, it's our normal skin. We were not intended to live in the dry desert of California. And so here's a patient who has particularly dry skin. And how do we treat this? Well, the main treatment to prevent itching from dry skin is moisturizing. Many of us think, when we hear the word moisturizers, we think that they're all the same. And we can pick one from a better company or a worse company, and that would be the true marker of the effectiveness of a moisturizer. Well, that's actually not too true. The truth is that moisturizers, there are 4 main types, and they vary in strength. The strength of a moisturizer is based on the vehicle. And what a vehicle is the mode of delivery of a medicine. And there are really 4 different types, and all moisturizers are a combination of oil and water, and the 4 types are different percentages of oil versus water. So the first 2 are solutions and lotions. In these 2 cases, the water content is far greater than the oil content. So if you were to try to moisturize yourself with a product that you see there on the left, it's just a fluocinamide solution, it wouldn't work very well. It would be like trying to moisturize your skin with water. And we all know that that doesn't work very well. In fact, things that have a lot of water in it tend to make us even more dry, because when the water evaporates, it tends to take some of the water in our skin with it. So anytime you take a bath and you come out, it actually makes you more dry after the water is evaporated. So water as a vehicle would not function well as a moisturizer. Now, as we add more oil into the water, the first step that we reach are lotions. Now, most of us use lotions. Why is that? They make us feel good after we've used them. They're not too thick and they're not too greasy, but they're still far more water than oil. Anyone who comes in with very dry skin that's causing a significant itch, dermatologists don't tend to prescribe lotions for them because the lotions actually make them worse. So you see here, the picture on the right is the characteristic look of a lotion. It does have a little bit oil to it, so it feels good on the skin. And when you initially put it on, it certainly does feel like it's moisturizing. But after a while, those lotions will evaporate, and they can cause us to become even more dry. So solutions and lotions we tend not to use as moisturizers, even though the lotions are extremely popular. Creams and ointments. These are where the oil content surpassed the water content. And the classic creams would be like Eucerin cream or Cetaphil cream. And if you took a lotion and you compared it to a cream, you would see that the cream is definitely thicker than the lotion. And when you apply these creams, they actually tend to moisturize far better than the lotion, and they don't evaporate. Now that can be troublesome as well, because you can see a white film on you all day long. But nevertheless, we try to moisturize with vehicles that have greater oil than water. So creams are a great option. The picture here on the right is of an ointment. And the most common ointment that we might use is Vaseline. Now you can imagine that when we put Vaseline on, it's far more oil than water. So much so that when you put your clothes on top of that, it can get pretty not comfortable, because you can see the oil kind of penetrating through the clothes. So as a result, sometimes we tend not to use the ointment simply because it's hard on the patient's lifestyle. You can't go to work very easily and have your oily ointment soaking through your clothes. So where do we fall on the spectrum of solution versus lotion versus cream versus an ointment? Well, if you really were moisturizing someone because it was an itch that was so bad that you needed to treat it, we would tend to use an ointment because it works the best. The problem is most people try to moisturize to be able to go through the day. And if that's the case, we tend to fall on using creams, because creams do work well. They are thick, but they're not as oily as ointments. And they tend to moisturize better than better than the lotions and the solutions. So the first treatment for our first cause of itching is moisturizers. Now, I like to educate my patients regarding something that I call the 3-minute rule. Everyone loves to shower. When we take a hot shower, it's one of the great pleasures of life. People really love it. It makes them feel good, except after the hot shower. If you are someone who itches because of dry skin, a hot shower makes your itch far worse. So what is the right way to take a shower? The right way for a patient with dry skin, there are just a couple simple rules. The first is, unfortunately, you can't use hot water. We have to use lukewarm water. So you want it where the water is just a little bit cold, colder than you're used to, and not hot, because it certainly does help to prevent itching to use the lukewarm water. The second rule is that you don't want to take a long shower. 15 minutes is all we permit. So you take a lukewarm shower for 15 minutes. And when you get out, pat dry. Now this is, I'm stealing one of the great joys from patients who itch, because when you get out, again, I mentioned it's so nice to do a vigorous dry, because that's the only time that a very diligent patient gets to scratch with their towel. Instead, we advise you just to pat dry, to get rid of the water on your skin by patting the skin until you're dry. And then you have 3 minutes from when you get out of the shower to apply your moisturizer. Why is that? If you've ever applied Vaseline to your hand, and you take a cup of water and you pour it on, you notice that the water beads up, and the water can't penetrate through that ointment because it's such an effective water barrier. And you turn your hand to the side, and that water comes off in beads because it's such a good barrier for water. When you get out of the shower, or when I get out of the shower, our stratum corneum, which is the top layer of our skin, it functions like a sponge, and it's filled with water. And so when you get out, you have 3 minutes before that water evaporates. So once you pat dry it and you get out and you apply the moisturizer, it does the same thing on the inside as it would do on the outside, meaning it traps the water inside your skin, and it moisturizes wonderfully. So lukewarm water, 15-minute shower, pat dry, and then your 3-minute rule. By the time you've gotten out of the shower, you have 3 minutes to apply your moisturizer, and it will trap the water on the inside just like it prevents water from penetrating from the outside. Does that make sense? It's a very simple way. I have a patient, or we'll talk about this at the end perhaps when we talk about different forms, when we address our questions. But anyways, this really does work if you have dry skin. The second cause of itching is fungus. Now, people might wonder, how common is tinea pedis, or athlete's foot? It's extremely common. It's very easy to pick up. You can pick it up from being at the gym. You can pick it up from walking on a surface where the fungus has resided recently. It's very easy to pick up athlete's foot. What does athlete's foot look like? If you look between the toes, the most common finding in athlete's foot is what we call maceration. It's an area where the skin is filled with edema and there's a little bit of a crack or a fissure. And these are intensely itchy. They're very inflammatory lesions, so what happens is the fungus is living in the skin, and it causes our white blood cells to come and attack that area, knowing that a fungus is there. So it causes a great itch. Here you see it between the 3rd and 4th digits of the toes, and it can get very exuberant. Larger areas of desquamation because of the fungus living there, causing great itching. These areas are extremely itchy to patients. Sometimes you can get it along the sides of your feet. And what you appreciate on this picture is you can see the skin peeling off, but you also see that rim of redness that we see right here. And this is all the inflammatory cells are coming in to fight against the fungus. This causes intense itching. And so if anyone who has ever had athlete's foot, you can know that this is the type of itching that can actually keep you up at night. Sometimes it involves our hands. And strangely enough, it'll involve one hand, perhaps, and not the other. Sometimes it involves both hands. Sometimes it involves your hands and your feet. And sometimes it can get very inflammatory. So again, you see here that there's not just scale, but there's erythema or redness. And that simply means that this is intensely itchy. And so it needs to be treated. The fungus needs to be treated in order to calm the white blood cells down. And you see that same inflammatory border here on the foot. You see scaling, and then you see that redness that's adjacent to it. Can you appreciate that? This little line of erythema that goes across the foot. So the athlete's foot is down here, and then the erythema from the inflammation is surrounding it. Very, very itchy. Now, when we scrape the foot and we look, the fungus grows in these little lines. We call these hyphae. And so if you've ever been to the physician and they want to find out if you've got athlete's foot, they'll scrape it off and they'll put it in some potassium hydroxide, and they're going to look under the microscope to see if they can see the fungal elements. And that's what it looks like. It's very subtle, but you can appreciate those linear areas of fungal growth. Now, how do we treat this? It's very easy. A good course of antifungals will do the trick. And a lot of these are now over the counter. And again, I have never taken a cent from a drug company. So these are just two examples of antifungals that we know work well. The one on the left is clotrimazole, and it's prescribed. And it works very well to prevent to treat the fungus. The one on the right is Lamisil or terbinafine. That also works very well, and that's over the counter. So you can buy over-the-counter medications, and you can also use prescription medications to treat the athlete's foot. Now, how do you treat it? You treat it twice a day, every day. Even when it goes away, I still advise my patients to continue using it, because people who have had it once tend to get it again. So we continue to treat, even if the patient's feet look clear. So that is cause number 2 of itch. Cause number 3, bug bites. Now this is a very famous bug. It's called Cymex lectularis. And if you've been keeping up with the lay press, these are called bed bugs. And they're making a significant resurgence. They're red bugs with a pretty big abdomen, and they tend to bite in what we call a breakfast, lunch, and dinner pattern. Patients come in who have bed bug bites, and they come in series of 3 linear papules. So I'm going to start, I don't think I'm starting with bed bugs. We'll talk about them in just a moment. I'm first going to talk about flea bites. Now, flea bites, we call them papular urticaria is our technical name for them. And they come from getting bitten by fleas. And the most common site is going to be this picture on the right. We tend to get it along our ankles. And the reason for that is if there are fleas from dogs or cats or other animals, they tend to be low-lying. They sit in the carpet, and when they're ready and you walk by, they bite you along the feet. And so you get these urticarial welts, and these are actually allergies to the saliva from the bite. And so sometimes we like to say that some people get bitten and others don't. Well, the truth of the matter is most everyone gets bitten, but some people react to the saliva and others don't. So the female flea will come and bite the base of your foot, and you get this linear, you can almost appreciate that breakfast, lunch, and dinner, and snack, and evening meal in a line there from that one particular flea. And sometimes people can get a very brisk reaction. If you see the picture on the left, you get significant swelling and we call it urticarial hives from the flea bite. So this is the most common presentation of a bug bite. It tends to be on the feet. If you lay down on the ground, you can get all over your body. Unfortunately, these things are very persistent, and they can sit around the carpet waiting for you for weeks. Mosquitoes. They are attracted to a number of the elements in your sweat. The warmth, the lactic acid in your sweat, warm areas, wet areas. And they can also cause these hives, and we treat them with topical steroids. And here we see mosquito advising Betty, pull out, Betty, pull out. You've hit an artery. And what we see here is it's very accurate because it describes the mosquito as Betty, and it's always female mosquitoes. And as you know, these are extremely bothersome. If you've ever gone camping, and you can get them all through your exposed areas of your skin, the best anti-mosquito bite topical preparations contain this product DEET, and they tend to work very well. But once you get them, the best treatment is a mild topical steroid like hydrocortisone that you can buy over the counter. Very common causes of itching. Oh, I'm sorry. This is what a flea looks like. I just wanted to show it to you. Scabies. Now, scabies is unfortunately very common. Scabies is the only one of these bugs that I'm describing that actually lives on you as a host. The others bite you, and they take off. Scabies tends to burrow into you and stay in you, laying eggs until your skin is filled with these mites. And this is what they look like. We can actually visualize them by scraping your skin off at the burrow and looking under the microscope. They're about 1/3 of a millimeter in size, so they're very small, but you can visualize them fairly easily. And I'm going to show you a video, if I could, of a case that I saw June 13th, 2002. So this is what they look like under the microscope. So you see it's got 4 little arms. You see it's moving its right arm there. There's its left arm. And they're pretty hardy. I mean, this is after I've scraped it off of the human host. You can appreciate that they move. And so it's similar to hitting a moving target as you're trying to treat these guys. You can see that they affect a part of the body that is, we call it the circle of Hebra, by Ferdinand von Hebra, the great dermatologist who described this. The pattern of itch that we see in scabies is a circle that involves the nipples, the armpits, the wrists, we call this the anacubita, the other side of your elbow, your genital area, and the belly button. And it itches in a circle. And it's an intense itch. It's the type of itch that keeps you up at night. And the problem with these these itches is that patients get it and they go for weeks, and no one can they treat with topical steroids. And what the topical steroids do is simply make the bugs even happier because you're getting rid of the immune system. So the bugs are really very, very happy, and they proliferate and they grow, and until someone figures out that this itch is far worse than any regular itch, and you get referred to a dermatologist, it's easy to treat. And how do we treat? Oh, I'm sorry, I just wanted to show you this particular picture because you can get what we call scabies nodules from where the bug bites the patient. You can get a nodule that stays for 3 or so weeks even after the scabies has been treated. If you appreciate the burrows there, they're in the little web spaces of the hands. Can everyone appreciate that? The scaling that might affect the interdigital web spaces. Again, very, very itchy in these areas. We treat it with this particular cream that's called Elamite. It's the best treatment that we have that's not a pill. And so what you do is you take this particular cream, you apply it from your neck down to your feet, you sleep overnight, you wash it off in the morning, and you repeat in 7 days. And this kills all the bugs in your skin. The problem is the dead bugs are still in your skin, so you can still itch for a little while until your skin has grown out and the bugs fall out into dust. So you kill the bugs, they stick around for another 3 weeks, dead at least, and then they slough off into the air and you finally get some relief. But this is Elamite. Now, people who have very serious scabies infestations, we have to treat them with ivermectin. And ivermectin is a pill that you would take, and it's a one-time therapy, and it kills the bugs in your skin, and it will kill any other parasite that you have as well. The last are the bed bugs that I'm showing you here. Bed bugs, this is on a human patient. What you see is that the bed bugs have a large abdomen, and again, they tend to bite in a breakfast, lunch, and dinner pattern. And the reason that a lot of people worry about bed bugs is that they've been known to carry hepatitis B. You know, the data are not yet very solid as to how dangerous that is to humans, but we have been able to find hepatitis in the Cymex lectularis. But again, usually in threes, they bite in a breakfast, lunch, and dinner pattern, and you can treat them with topical steroids as well. And then you want to get rid of your mattress. Okay. Now, item number 4 is a big item, because there are tons of things that cause allergic contact dermatitis, things that touch your skin that cause you to itch. This is probably the most common cause of itch. Now, sometimes people ask me, well, how do you diagnose allergic contact dermatitis? And I will talk about that in just a moment. It should be stated that allergic contact dermatitis is not the same type of allergy as you would imagine from pollen or peanuts. You've heard of people who eat peanuts and all of a sudden they can't breathe, or cat dander. Allergic contact dermatitis is something that touches your skin rather than something that you've inhaled, ingested, or injected. So if you inhale pollen and you have a difficult time breathing, that's what we would call a type 1 hypersensitivity. Or if a young lady eats peanuts and all of a sudden she can't breathe and her throat closes up, that would be a type 1 hypersensitivity. Allergic contact dermatitis is a type 4 hypersensitivity. So what that means is something that touches your skin, like poison ivy. So when poison ivy touches your skin, you get a big rash. It's because it's a type 4 hypersensitivity. Now, there's minimal cross-reactivity. If someone were to eat a peanut and they would have a difficult time breathing, if that same person took the peanut and rubbed it on their skin, they likely wouldn't get a rash. But if they ate it, they likely would have a problem breathing. On the other hand, if someone took poison ivy and rubbed it on their abdomen, they got a huge rash. If somehow you could make that poison ivy into a very strange salad and put it into your mouth without letting it touch your lips and swallowed it, you probably wouldn't get difficulty breathing. There are two different sets of allergies. So when we ask about a contact allergen, it's something that's touching your skin, not something that you're eating or inhaling. And they're tested differently. When you want to test for a type 1 hypersensitivity, we have to inject that antigen into your skin. So it's called prick testing. Many of you might have had this done in the past, where they'll actually poke something into your skin to see if you have a reaction. That tests for the type 1 hypersensitivity. It does not test for type 4 hypersensitivity. When we test for a type 4 hypersensitivity, it's not tested that way. It's tested with stickers on your skin to see if we find something that touches your skin that causes the rash. So many times when people come in with a type 4, they inadvertently get the wrong type of testing done. They get the prick testing done. It doesn't make the diagnosis. We're talking about a type 4 that needs to be tested by what we call patch testing. And I'll talk about all the common things that can cause this type of a reaction. The first is rubber. We always say that we have a latex allergy. In truth, it's not really a latex allergy. It's usually what we call a rubber accelerator. So as you can see, this patient who's wearing this particular glove developed a rash there on the wrist. And that's a common cause of an allergic type 4 hypersensitivity. Sometimes when you look underneath the skin, you can underneath the glove, you can see this pattern of these little almost blister-like lesions that can be intensely itchy. So if anyone has ever worn rubber gloves or any type of glove for that matter, and you can get a rash from it, it's most likely caused by the rubber accelerator used to make the rubber rather than the pure latex itself. But we always use the word latex allergy, and dermatologists understand what that means. Now, don't be distracted by the cool necklace. Okay? What we're looking at is a different type of a rubber allergy, and it's from her bra strap. Can you appreciate that? You see the dermatitis that's coming down here along the chest wall that's caused by the rubber accelerator in the bra strap. And if you were to look at this patient's back, you'd see it all the way across where the strap might have sat on her skin. And also, if you looked at the waistband, you can see that particular pattern. So again, rubber can cause lots of cutaneous allergies. This was a patient of mine from San Diego. What you appreciate here is from the rubber flip-flops. They got a very geometric rash. So what you can appreciate from contact dermatitis is that it tends to follow patterns. You can see it on the skin based on what touched the skin to cause that particular rash. Moving on. Do you have any idea what this patient might have been allergic to? Any guesses? What's that?
Some type of metal.
Metal, exactly. Nickel. Nickel is the most common metal allergy. And so you see that if you were able to move that patient's watch right over, you see that little square where he was allergic to the nickel. Nickel is an extremely common allergen. And most patients who get it, they can get it around where they have their earrings or on their belly button area where the metal snap of a jeans sits on the abdomen. Or in this patient's case, behind their watch. That's from their strap, the little buckle on their watch strap. The strap itself didn't cause the dermatitis, but where the latch fell on the skin, it caused a little contact derm there. This was that patient, the clinical scenario I mentioned earlier. Very commonly, if you were to look at the back of this jean area, you'd see the button on the back is made out of nickel. And so people get this is the most common site of nickel allergies. They scratch and scratch, and after a while the skin thickens like that. We call that lichenification. This patient has a very curious rash here on the cheek. And if you didn't know better, you start thinking about other things like basal cell cancers. Until you ask him to put on his glasses, and you realize he was allergic to his eyeglasses from the 70s. So you see that? That's exactly where the contact from his glasses caused the nickel allergy. May I ask, does anyone have a nickel allergy in the room? Someone's from Nora's raising it. Yes, it's very common.
Other metals also cause?
Other metals can. Gold thiosulfate can. Mercury can, or mercury similar compounds can, but nickel is the most common. Yeah. Okay. This patient had a nickel allergy, and when we patch tested them, we found out that it was a very strong nickel allergy. And the reason is he put his coins in his pocket, and when he sweat, the antigens from the coins penetrated through the cotton lining of his pocket and caused this particular allergy. And it can also be found in keys. So for these patients, what we do is we just have them put a Ziploc bag in their pocket and put the coins and the keys in their pockets, Ziploc it, put it in there, and they do wonderfully. But nickel is extremely common as a skin allergy. This poor gentleman went camping and picked the wrong leaf when he wiped his bottom. So this is poison ivy. And poison ivy is also known as Rhus toxicodendron, and the antigen is called urushiol. And far more than half of Americans are allergic to poison ivy. And we have a saying in dermatology, if the leaves be three, let it be. So if you see a plant with 3 leaves in this particular pattern, this happens to be poison oak, because on the West Coast we see a lot more poison oak than poison ivy. But nevertheless, it's still 3 leaves. If you get it on your clothes and you put your clothes away for a half a year and you put the same pair of pants back on, you will still be allergic to it. If your dog runs through the leaves and comes out and you pet the dog and you don't wash the dog, it will stick around for a long time. Poison ivy can cause linear streaks of itching on your skin because we tend to get it in lines. We brush by the poison oak and we get a line of dermatitis on our legs. So it's very common, and most of us are allergic to it, and we have to treat it with topical steroids. The other thing that a lot of people are allergic to are adhesives, bandages. So some people will get it from simple Band-Aids. A lot of people who like to build model airplanes, they get desquamation or peeling of their distal fingertips. It's from the glue or adhesive that they might be using. One of my favorite stories is I had a patient who had the worst hand dermatitis. And I was convinced that he had a contact allergy. I didn't know what it was to. And he didn't either. I patch tested him, and it was to epoxy. So I asked him, sir, do you use glue in any way? And he said, no, I don't. I asked him to really rack his brains to see if he could use any. He denied it. But he was so happy that I had diagnosis for him, he came back to the follow-up 3 months later, and he brought in a really beautiful end table. And he gave it to me, and I looked at it, and I said, sir, that's really nice. He said, I'm giving this to you because you diagnosed me. And I said, your hands still look terrible. He said, yeah, he was just very happy that I figured out he was allergic to glue. And I said, sir, did you make that for me? He said, yes, I did, and I spent a long time on it. It was covered with glue. And so what had happened was this hobby of his building carpentry, he didn't associate it with glue as an Elmer's glue or wood glue. He didn't put the two together. And so I had to make the debate as to whether or not to tell him to stop making these end tables, which he loved doing, or treat his hand dermatitis with some clobetasol. And I looked at this old gentleman who just loved it. I said, listen, sir, just keep building them, and I'll just treat you for it. Because it was what gave him his peace. So, I never really caught up. His hands were always kind of, peely, but at any rate, he was happy. So, again, glues can cause a lot of allergies. Fragrances. Now, fragrances are extremely common, right? So, and oftentimes people will develop allergies on their central chest from their perfume. The other common place to develop a fragrance allergy is over their whole body from the fragrance in their Tide detergent or whatever detergent they use. And they put it on and they get a horrible rash from a new detergent. And in this case, there's a fragrance in toothpaste. And this is one of the most common causes of peeling lips and itchy lips. It's from the cinnamic aldehyde fragrance that's in toothpaste. So people brush their teeth, they get this horrible dermatitis, they can't figure it out. Finally, we realize that it's from the toothpaste. We stop the toothpaste, and they do wonderfully. We, of course, don't want them not to brush their teeth. So we switch them over to a toothpaste that doesn't have cinnamic aldehyde in it. But one of the most common causes of lip dermatitis. What are the others? Mango rinds. If anyone eats mango out of the rind, they can get a really bad dermatitis. And the other common causes of lip dermatitis are lip licking. Some people just do it all the time. And the best treatment for that is a cream that's called metronidazole cream. People always ask me, why does that work? Well, I'll tell them it works not because the medicine does anything, but the medicine tastes absolutely terrible. So you put it on and people stop licking their lips because it just tastes terrible. So anyways, those are the common causes of lip dermatitis that might cause itching around the lips. And here you see that patient who puts her perfume on, and you get a rash right there from the fragrance. And what we can actually do is patch test you, figure out which fragrance it is, and then you can go and purchase a perfume that is free of that particular antigen. So there are plenty of perfumes that are free of particular antigens that might cause a rash like this in different patients. It just depends exactly on which fragrance you're allergic to. Oftentimes, they'll also get it in their armpits from their deodorant. So very common. The most common cause of periocular rash, itching on your eyelids, is tosyl amide formaldehyde resin, which is nail polish. So people don't realize it, but their nail polish is the most common cause of rashes along the neck and along the eyes. And people don't know that they can put even like some mild see-through nail polish or go to a manicurist, and they come home and they get this itchy rash around the eyes, and it's commonly caused by nail polish. So this is unfortunately very common as well. So if you have
because she touches your eyes?
Because you touch your eyes. Mm-hmm. So if you have a friend who comes in sort of looking like a raccoon, just look at their fingers to see if they had their nails done recently. Very common. This patient had a basal cell cancer removed from the left forearm. After the cancer was removed, the patient was treated with neosporin. Neosporin is a horrible antigen. It's extremely common allergy for many patients. So people like to use a neosporin. Let's say someone gets a little bit of a lip licorice dermatitis, and they put the neosporin around their lips, and then their lips explode. Neosporin is extremely common as an allergen, but if you've used it before and you have no reaction to it, it's just fine for you. But some people do get it, have this allergy, and they can't figure it out until we patch test them and realize they're allergic to that neosporin. This poor young lady dyed her hair. And people who dye their hairs can get horrible facial rashes there's an antigen called paraphenylenediamine. So it's a very common antigen. The other is through hair perm. And the hair perm solution can also cause a very bad contact dermatitis. So it's another very common cause of itching. So if you know someone or you yourself have gotten facial itching or itching on the neck and you don't know why, and you can correlate it back to when you started to dye your hair, it's a very common cause. So I'm just going to finish off by showing you how we diagnose a lot of these conditions. This is called the thin layer rapid use epicutaneous test, or we affectionately call it the TRUE test. It's basically all these stickers with a whole bunch of antigens in the stickers. So when we peel the stickers off, you see those little square areas that actually have the antigen impregnated into the adhesive. Now this is the way that most dermatologists perform this particular test, and it's 29 antigens. And so if you get this put on you, if you're really itchy and you want to find out, we put these 29 antigens on you, and sometimes we can find out what you're allergic to. Now if that doesn't work, then you get referred to Stanford, where we don't just do the TRUE test, we do what's called the full spectrum patch test. And those, if you see that ointment up there, we're actually putting the actual antigen into these chambers. And then we tape them onto your back so that you look mummified. That's 80 antigens on your back to sort of figure out what you're allergic to. And what I'll do is I'll also ask the patient to bring their own household products. I take those products and I mix them in with a vehicle, and then I'll tape them on their arms, their legs, and I'll try to see if I can find the cause of someone's rash that way. And if you were to be positive, this is what it would look like. You see that little blistering area? That is a positive patch test. And so I know that this patient is now allergic to Thiram. And what I can do at this point is I can actually generate a little pamphlet for the patient that is filled with products that they are not allergic to. So I'll put Thiram into the computer, and it generates a little book. And every time they go to CVS, they can take the book with them. And if they wanted to buy a moisturizer, they can open up the page to moisturizers, and everything in that little book is free of the antigen that they're allergic to. And it's really helpful. People go on for 7, 8, 9 years with this chronic rash or itch. They can't figure out why, and once they come for the patch testing, we find out what they're allergic to. We generate this book for them. They go and only exclusively use the products in that book, and they're free of the rash from then on. It's the purest form of prevention. Find out what you're allergic to and avoid it. You don't need to take any medications. It's really very satisfying when we can do that. Now, what is the main therapy that we use for itching? The cause of itching is the inflammation in the skin, the white blood cells that have come up to the surface skin. And so the best way to treat it is with topical steroids. Now, topical steroids need to be used with care. And there are 7 different strengths of topical steroids. And everyone's always really worried about them, and with good reason. What are the most common side effects of using topical steroids? The first is, with overuse, is atrophy. What happens is your skin thins. And when your skin thins, the way that you can tell that it's thinning is you can see your blood vessels underneath the skin. So can you appreciate that on this bottom picture here? We call these telangiectasies, the small blood vessels that you can start to visualize. Now, to tell you the truth, as we get older, our skin thins by itself. But there's no reason to hasten along with super potent steroids. We want to avoid that particular side effect. Now, what's the most fearsome side effect? It's stria, or stretch marks. If people use steroids too much, you can actually develop stretch marks on your skin that are very unsightly. And there's nothing that we can do to get rid of a stretch mark. You know, no matter what cosmetic dermatologist is advertising the newest laser, the literature suggests that nothing works for stretch marks. You can get rid of the redness a little bit, but you can't get rid of the thinning. So these are the main side effects. Now, that said, a dermatologist who knows what he's doing will never put his patient at risk for developing either of these. How do we control that risk? There are 7 classes of steroid strength. Class 1, the most common types is clobetasol. And there's another product that's called Ultravate. And there are a whole bunch of different types of steroids. Class 1s are the strongest. We only use these when we need to. And we use them on very thick plaques. So if someone comes in with really bad psoriasis, we could treat with clobetasol. If someone comes in with a chronic itch, if you remember that picture of that gentleman with the nickel allergy along his lower abdomen, in a case like that, we would use clobetasol. It is by far the strongest topical medicine that we have. And it works very well, but we don't want to apply it to the parts of the skin that are already thin. Eyelids, armpits, genital area. Those are the parts of the body where the skin is either the thinnest or there's increased penetration because skin touches skin. So underneath your breast area, or if you have an area where your skin on your abdomen touches another part of the skin, we would never want to put clobetasol in that area simply because it can increase the penetration. Now, I shouldn't say never. There are focal times when we have to do it, but we have to do it very carefully. But normally, we never use class 1s for that. The product underneath is called Lidex, or fluocinolone. That's a class 2. Now, we will use Lidex very frequently in areas with thicker dermatitis, but we use it very carefully. We have the patient use it for a limited period of time, and then we stop. We never want to use it for a year at a time. Sometimes if patients keep needing it, I'll tell them you can use it Monday to Friday, but you always have to take off a week between uses. And that tends to eliminate the risk of the atrophy or the stria. So these are class 1s and class 2s. We use them when we need to for very thick plaques. Class 4s are used for daily maintenance, and most of you have probably been prescribed. This is triamcinolone. I don't know if anyone's ever used this before, but it's a very, very good product. It's a class 4. It's mid-strength, but still we want to avoid contact to the face, the genital area, or the armpits. Again, I have never taken a cent from any company, so I'm just letting you know some of the products that we use commonly that are affordable and effective. And triamcinolone is that. Again, though, there are side effects, and we need to be careful to avoid chronic use in any of these areas. Class 5s and class 6s, they tend to be very safe. We can use it on the face, eyelid dermatitis on occasion for a short period of time, or even on the genital areas. And this is fluocinolone, which is one of the common class 5s that we might tend to use. And again, they are risky if you use them for a long period of time. I had a young lady who came to my clinic last week. She had been using it on her face for a year. These tend to be very safe if you use it for a week, 2 weeks, even 3 weeks. But to use it for a year, she already had thinning of the skin at the age of 24 with superficial blood vessels showing up. So we don't want to use these for long periods of time, but you can certainly use them for shorter periods of time. Finally, class 7s are over-the-counter. This is for use on the face, genital area. You can use them on babies, newborns. Very, very safe. And again, though, we don't want to abuse these by using them nonstop. But you can very easily use this for a matter of weeks, months, and you don't necessarily will develop any problems. If you notice here, it reads maximum strength, cortisone. This is the weakest product that we have, but it's the strongest of the over-the-counters. Now, I did want to advise you on one thing, and that is that sometimes people get confused by the percent strength. And they think that, well, this particular product is a 0.1, so it's got to be stronger than the clobetasol here, which is a 0.05. Now, as you know, the clobetasol is far stronger a product than the class 4 triamcinolone, even though the percent strengths, this would suggest that it's higher. So don't be fooled by the percentage strength. It's the active ingredient that tells you how strong the particular medication is. That is the conclusion of my lecture. I think I went over by about 10 minutes. I apologize. But I'd be happy to take any questions at this time. Yes, please.
So there's another chemical that's in our environment that some people are very sensitive to, and very few people are aware of what it is and why, including most medical doctors. That chemical is chloramine. It is used to disinfect our water. It is a mixture of chlorine and ammonia. And some people, me for instance, get terrible skin rashes with it. Some people have digestive problems, and some people have respiratory problems, and some people have all three. If you don't believe me, I can show you my photographs.
No reason not to believe you.
Okay, yeah. I've had to stop using all tap water, 100%. So if you or anybody you know has a persistent skin problem that doesn't seem to be able to be identified, you might consider the water.
Thank you. Please.
When you were talked about showering, I noticed you didn't have any negative things to say about soaps.
Well, soaps, soaps can certainly dry you out. And so what we do is we advise patients to use soaps every other day if they can. So you rinse one day, and then you can soap the next day. The most important thing about the soap, though, is whether or not there's a fragrance allergy in it, and that happens all the time. And it should be noted that unfragranced products are very different from hypoallergenic products, or I should say non-fragranced. What they mean by that is they mask the fragrance with another fragrance. So you can have a fragrance in the soap that doesn't smell very good, and they mask it with another fragrance to get rid of the original fragrance. That's an allergen in and of itself. Hypoallergenic soaps tend to smell a little bit strange, but that's how soaps smell. And so we advise those patients to use hypoallergenic soap. Yes, please, sir.
I take oral medication for diabetes, and I feel that some of them I cannot isolate. It's causing some allergic reactions.
That may be. In a case like that, it would be what we call a type 1 allergy, like I had mentioned earlier. It's something that you eat. So dermatologists wouldn't be able to diagnose that from a patch test. But if you feel that way, there are a whole number of different good diabetes medications. And if you feel that there's one that might be causing that, you should talk with your primary physician to alter that, to see if it can relieve the bother. But if it's not that bad and dermatologists can treat it, we can give you some of these mild topical medications, and it may help you to control the itch even as your diabetes is controlled, particularly if that medicine works very well for you. So there's a whole number of things that we can do to try to help you with that.
But it's very difficult to isolate because I take like 4 or 5.
It is very difficult to isolate. You're exactly right. So sometimes it's easier to treat the symptoms. Yes, please, sir.
What about a genital itch that doesn't present with any redness or appearance of rash?
Yeah, that is very common. We call that scrotal pruritus. And unfortunately, in a situation like that, there are many different causes. One can be what we call tinea cruris, or jock itch. In most cases, there's a scale that's associated, but sometimes patients don't get that scale. What jock itch is it's caused by 3 organisms called rubrum, mentag, and flocosum. I affectionately call them rub, me, flow. And they cause this jock itch, and they're the same organisms that cause athlete's foot. So what happens? The most common cause of that is when people put their underwear on, they transplant the rub, me, flow from their feet up to their genital area. So when we treat the jock itch with these over-the-counter medications or with an antifungal, we advise the patient to treat not only the genital area, but also the feet, because there can be cross infection. Now, if it's not infectious, people can actually develop scrotal pruritus from nerve problems, from spinal stenosis, so problems with the spinal canal. They can get it from a whole host of inciting factors. And so it usually takes multiple visits before we can figure out how to help that particular patient. And because of the anatomic area, it's very hard to use some of these medicines because we don't want to apply them to the genital area.
I did go online and saw a number of patients, people that responded, and they talked about trying a whole list of
Oh,
things
yeah.
with no
Oh,
effect.
yeah. Oh, yeah. It is a very, very tough.
It doesn't seem to bother during the day, and it's not. I just figured, why bother if somebody has spent 3 or 4 months and then had no results?
Yeah, it can be very, very bothersome to a patient, and we throw everything we can at it because we want to help the patient to feel better. But it can affect them in the daytime. It can affect their sleep, and so we try to be as aggressive and safe as we can. But there's a very systematic way by which we will approach it. Yes, please.
6 months ago, I had a rash that spread all over my body from my head to my toes, and to my ankles, I should say. And none of the dermatologists could figure out what was wrong, and they tried prednisone, and anyhow, it apparently is my immune system attacking itself. Is that something that happens where the immune system can attack itself?
Yeah. In the past, we used to think that the skin was just a big sac, and inside the sac you had bones and heart and such. And now what we realize is that the skin is really an immune organ. And there are multiple antigen-presenting cells in the skin. And it's very common that the immune system can get revved up in the skin. Attacking itself is probably not the right word, because when we think of that terminology, we think of an autoimmune process where your skin is literally attacking some antigen in your cells. And that's very dangerous. But what can happen is that your immune system can get revved up and be turned on nonstop. And the only way to relieve the itch is to turn off the immune system, which is why you were given the oral prednisone. The prednisone is a way to turn the immune system off in the skin. But the most important thing is to find the trigger. What was it that caused your immune system to turn on, and try to deal with that? Because if you don't, then you're masking the symptoms by giving you the prednisone and not figuring out what the initial cause was of the itch. So dermatologists should go on a hunt. And the hunt would include many of the things that I talked about, particularly the contact allergies. So it's, again, a very systematic process by which we investigate what might have triggered your rash. But to answer your question, yes, it's the immune system that's causing the itch, and it can get revved up, and we sometimes can't figure out why that happens.
Well, for me, the prednisone didn't seem to work, but methotrexate does.
That's exactly right. So methotrexate is another way to turn off the immune system. Celcept, Imuran, cyclosporin, these are all medicines that we might use to try to turn off your immune system.
So wouldn't you have to be careful to not get infected with like cold germs?
Absolutely. So when we give people these medications, we have to be very careful because they can get secondary infections. And so we follow them very closely because they're pretty strong medications. Yes, please, sir.
I have occasional, quite often, little red raised bumps. Are these always insect bites?
No, they're not always insect bites. We call those papular urticaria, and that can happen for a whole number of reasons. They can be insect bites, but they can also be many of these things that we've brought up here. A contact allergen, a new drug that you might be taking can cause little red bumps. There are many different causes of that. And unfortunately, in every case, it's an investigation. We have to figure out what was it that might have caused this to help you prevent recurring itchy red bump disease, which is literally what we call it, itchy red bumps. Yeah, because sometimes we just can't nail down what caused it.
But hydrocortisone, you indicated would be a very mild,
Very mild. And you can definitely use it on those itchy red bumps.
and you get I got a reaction from hydrocortisone.
Yes. So unfortunately, I didn't go through all the contact allergens, but hydrocortisone itself is a contact allergen. So yes, you're exactly right. And there are families of steroids. So I had mentioned Lidex earlier. Lidex cross-reacts with triamcinolone. So if you're allergic to Lidex, you can't use the triamcinolone. So it gets more and more complicated, but I didn't want to dive into it. Yes.
Benadryl.
Benadryl is an antihistamine, and in some cases...
Probably it covered, I ended up with a full body rash.
Oh yeah, you can be allergic to many of the vehicles. A lot of the the products have a lot of fragrances in them. Yeah, it's true. It's true. It's not an exact science, unfortunately. Yes, please.
Are there instances when exposure can actually induce resistance to the allergen?
Are you speaking of sensitization?
Yeah, I think so. Where someone's wearing a nickel watch, they wear it over and over again, and eventually they
Yeah,
lose
usually
their allergy
not.
to it?
Usually not with contact dermatitis. Usually not. With type 1 hypersensitivities, that of course is well described, but with type 4s it tends not to be that way. As people use it more and more, it gets worse and worse. And unfortunately, then we start scratching. And when we start scratching, the skin reacts to scratching similarly to your feet react to poorly fitting shoes. The skin starts to get thicker and thicker and by itself chronically inflamed. So the itch-scratch cycle is something that we have to break. And so with contact allergens, it tends not to happen that way. Yes, please.
I'm curious, you didn't mention anything about food-induced rashes.
Right. So food-induced rashes, believe it or not, are less common than some of the things that we've mentioned today. But everyone is different with that. Different people have different type 1 hypersensitivities. Of course, there are things that we consider common allergens, such as dairy products or shellfish. These are common allergens, but they tend to cause a type 1 hypersensitivity rather than the type 4. That's not to say that a type 1 hypersensitivity can't cause itching, because it can. There are many things I didn't mention today. But if you do develop a rash that tends to be more welt-like or hives, you can search through what you're eating, create a diary, and see if we can figure out what's triggering that and avoid those things. And if not, you can see an allergist, and the allergist can perform the prick testing to figure out what you're allergic to. But it's a wonderful question. Yes, please. No.
Can I take-
Yeah, please.
Okay. About half a year ago, my daughter had some rashes, hives, and then finally the dermatologist figured out it was caused by gluten. But interesting enough, after she stopped eating any gluten-related food, her doctor said eventually she can get back to have some bread or pasta. So it's not a permanent type of...
That's correct.
Okay.
That has more, again, to do with ingested, things that you eat. And that can be. Now, I don't exactly know what situation your daughter was in. There are gluten sensitivities in the skin. The worst is something called dermatitis herpetiformis, where patients have to completely avoid any of those foods. I'm not sure the exact scenario, but in general, that can be true. Yes, please.
Could you talk something about food coloring and pills?
Food coloring and pills. Yes, I don't know that, I assume that they can cause allergies in certain patients that might result in skin rashes. I've not heard of that in the sense that that would be more in the realm of what an allergist would know about. From the point of view of dermatology, our expertise is really in type 4 hypersensitivity. Again, the type that touches your skin. So, many people are allergic to many different things. And the way that, again, that you would test is with these prick tests. But I wouldn't have enough expertise to be able to answer that intelligently. So I apologize.
I'm allergic to the yellow,
Yeah.
which I discovered
Some people do,
in
yeah.
one of the pills that I was taking.
Mm-hmm.
But once I stopped that and avoid any yellow coloring, food coloring?
Yeah. The power of a patient's own perception and observation is huge. And so when patients come and tell me that they notice something, I always listen to them. There's no reason not to. Patients know so much more about their own bodies than physicians give them credit for. And it's really nice that you were able to identify that. And you can avoid it. And you know, patients are their own best advocate. And it's really good that you're able to do that. Are there any other questions? Yes?
Excuse me, are skin tags considered a rash?
Skin tags are not considered a rash. Skin tags tend to be inherited, and they're little outpouches of normal skin tissue, and they're easily removed, but they're not a rash. Now, if you try to get rid of a skin tag using the method that many, what's the right way of saying this? Mothers have passed on to children through the years by taking a piece of hair off and tying it around the base of a skin tag to try to strangulate it, which a lot of people do. I would advise not to do that, because we get patients who come to a clinic who've tried that and they get a big necrotic. So don't do that. If you have them and you want them taken care of, come to the clinic. Yeah. Yes, please.
You said a little bit earlier about scabies. Can it affect the face?
Scabies tends to spare the face initially, and it tends to affect this circle of Hebra that I described: armpits, nipple area, antecubital fossa, wrist, genital area, and belly button in a circle. It tends to spare the face until it gets very severe. It can affect the ears and the face, and we usually call that crusted scabies. That's in patients who are immunosuppressed, and it's very, very aggressive scabies, and they require multiple treatments and fairly significant disease. Yes, please.
These freezing treatments that you can get just over the counter.
Yes.
For warts. So is that fairly, I mean, you just sort of, if you've got a little bit of something that's been there for 6 months and you finally decide, what's the trade-off, going into the doc or just buying?
That's a great question. The reason that we use these cold therapies is to create frostbite enough to get rid of a growth on the skin. The type that you buy over the counter is 50 degrees below zero, very cold. The liquid nitrogen that we have in canisters in the dermatologist's office is 180 degrees below zero. So it's much colder. Now, if you can't treat it on your own, it's very convenient. You can just freeze it. I would say the benefits of coming in are, number one, the physician gets to lay eyes on it, so we know exactly what it is before we treat it. Many people have treated basal cell cancers or squamous cell cancers at home, and they don't really realize that there's actually a little bit of danger there, and we need to biopsy it to make sure that's not anything, one of these non-melanoma skin cancers. So a dermatologist gets to look at it and then freeze it with an instrument that's much colder. But to tell you the truth, so many patients are used to seeing their own warts. They know exactly what they look like. You know, if you can do it on your own at home, it's convenient, you should do it. It's no problem. And you can also couple that with some of the salicylic acid treatments that are over the counter, the ones that are 17 to 40%. And you can just put a little piece of salicylic acid tape on top of it, and then remove it, freeze it with a little canister, and if it still doesn't get any better, come on in and we'll take care of it for you. Yes, please.
I have 2 questions. The first one is, over-the-counter soap, detergent, say, for sensitive skin, is that good enough? The second question is, I kind of itch at night, just kind of over the body, and in the morning it's fine. It doesn't have a rash or anything.
Very common. Very common. So regarding your first question of whether or not sensitive skin products tend to be good enough, you know, most products are good enough for the population, even the ones that are not sensitive skin. Most people are not allergic to most of the fragrances that are out there. And if you're using a product that smells and you don't have a rash to it, you're totally fine. You can continue using it. There are a lot of people who are allergic to sensitive skin products, because sensitive skin products are definitely not hypoallergenic. You know, or I should say free of antigens. Some people are still allergic to those items. People also sometimes come in to say, well, why am I allergic to this? It's all natural. Poison ivy is all natural. You know, it simply means that there are antigens everywhere. And so basically I advise patients that if something's working for you, don't change it. And don't fall for the gimmicks either. And so you should just try something. If it works, stay with it. Now, regarding the nocturnal, the itching at night, a lot of people describe that. And the advice that I would give for that is the first thing to do is moisturize. It really, really does help. You know, it's amazing, during the daytime we actually have a lot of self-control, but at night it tends to go away. And so if you can moisturize very well, it does tend to help. Well, thank you for your attention. I appreciate the invitation to come.
For more, please visit us at stanford.edu.